Hi, I'm Dr. Manal Ali. I'm a phoniatric consultant. I'm going to speak about assessment of dysarthria. Dysarthria is a motor speech disorder that characterized by any combination of disorders, respiration, phonation, articulation, resonance, or prosody that may result from neuromuscular disorders which lead to weakness, slowness in coordination, and change in muscle. There are 6 types of dysarthria: flaccid dysarthria due to lower motor neuron lesion, spastic dysarthria due to upper motor neuron lesion, ataxic dysarthria due to damage to cerebellar control circuit, hypokinetic dysarthria Parkinsonism due to damage of basal ganglia control circuit, and hyperkinetic dysarthria chorea due to damage of basal ganglia control circuit, mixed dysarthria due to damage of multiple motor systems. The goal of assessment of dysarthria is to diagnose the specific type and severity of dysarthria and to guide a tailored treatment plan focusing on improving speech subsystems and intelligibility and overall communicative participation. The assessment of dysarthria. Number 1, the patient interview, which include personal data, name, age, sex, address, marital status, number of children, education, special habit, alcohol, smoking, and handedness. Complaint, onset, course, duration of the problem. If it is acute onset and regressive course, this pointed to trauma, inflammation, vascular causes. If it is gradual onset and progressive course, this pointed to neoplasm and degenerative disease or toxic and metabolic causes. Remitted course, this pointed to multiple sclerosis cause. The present history, which is analysis of the complaint, you ask about the prodromal symptoms: headache, vomiting, blurring of vision, numbness, tingling, and weakness. Then you ask about the symptoms of cranial nerve affection, trigeminal nerve, cranial nerve number 5. There will be difficulty in mastication and abnormal face sensation. If it is facial nerve, cranial nerve number 7 affection, there will be accumulation of food behind the cheeks. And if it is glossopharyngeal or vagus nerve affection, cranial nerve affection, there will be nasal tone dysphonia, nasal regurgitation of food, and dysphagia. If it is hypoglossal cranial nerve number 12, there will be difficulty in speaking and swallowing. You ask about the level of consciousness, coma, semi-coma, stupor, drowsiness, consciousness, and other neurological deficit, hemiplegia, involuntary movement, sensory disturbances, convulsion, swallowing difficulties, and bladder disturbance. Motor disability, if it is in the upper limb or lower limb, right or left, and the severity of the disability. Present means of communication of the patient, affection of vision and hearing, previous investigation, and previous lines of treatment. The past history: relevant disease, diabetes mellitus, hypertension, heart diseases, coronary heart disease, myocardial infarction, valvular heart disease, subacute bacterial endocarditis, TB, trauma, fever, syphilis, epilepsy, drug intake or operations, similar episodes and related episode, transit ischemic attack. Then you come to the clinical examination, which include auditory perceptual assessment, ABA, and oral mechanism cranial nerve examination, the cranial nerve number 5, 7, 9, 10, and 12. Then you go to the neurological examination and formal testing. The auditory perceptual assessment include the respiration, phonation, articulation, resonance, and prosody overall intelligibility assessment. differential diagnosis in ABA between the 6 types of dysarthria. In flaccid dysarthria, in respiration, it will be audible inspiration and frequent air intake. Voice sounds breathy, voice and harsh voice. Articulation, there will be imprecise, consonant, resonant, hypernasality, nasal emission, and prosody. Monopitch, monoloudness, speech intelligibility will be poor in severe cases. In spastic dysarthria, respiration is labored, uncoordinated. The voice sounds strained, strangled voice, low pitch, pitch breaks, voice stoppage, excess loudness variation, articulation, imprecise consonant, distorted vowels, and resonance. There will be hypernasality, and prosody. There will be slow rate, reduced stress, monopitch, monoloudness. Speech intelligibility will be poor. In ataxic dysarthria, respiration is incoordinated. The voice sounds harsh, voice excessive loudness variation, and articulation distorted vowels, imprecise consonant, irregular articulatory breakdowns. And prosody, there will be excess and equal stress, prolonged phonemes and intervals, slow rate and appropriate silences, monopitch, monoloudness, and speech intelligibility poor in severe cases. In hypokinetic dysarthria, Parkinsonism, respiration shows short rushes, and voice sounds harsh voice, breathy voice, decreased loudness. Articulation shows short rushes of speech, imprecise consonant, increase or plus hypernasality, and prosody shows short rushes of speech, final decay, reduced stress, monopitch, monoloudness, and inappropriate silences. Speech intelligibility is poor. In hyperkinetic dysarthria, chorea, and athetosis, the respiration is uncoordinated, voice sounds harsh, voice excessive loudness variation, and articulation distorted vowels, imprecise consonants, and prolonged phonemes, plus or minus hypernasality. Prosody shows excess equal stress, reduced stress, inappropriate silences, slow rate, variable tonality, bizarre, and the speech intelligibility is poor in severe cases. Then you ask the patient to prolong the vowel a to test the maximum phonation time. Usually it is short, and then you make the diathokinetic movement examination by asking the patient to repeat the syllable rapidly as possible, beta ka, and assess the rate, normal, slow, rapid, or variable, duration of syllable repetition, normal, reduced, prolonged, regularity of alternative movement of articulator, regular or irregular. Then you make the oral mechanism cranial nerve assessment that examine the cranial nerve responsible for speech process, number 5, 7, 9, 10, and 12. And look for the upper motor neuron versus the lower motor. In the cranial nerve, number 5, trigeminal nerve, examine muscle of mastication, masseter and temporalis, examine pterygoid power, jaw, and examine jaw position, deviation, and jaw reflex. In upper motor neuron, pseudobulbar palsy, there will be the mandible movement are well preserved, but often immature or poorly coordinated. Jaw jerks, reflex present or exaggerated. Tonic bite reflex may be present. In bulbar palsy, lower motor neuron lesion, mandibular movement are usually minimal or absent. Absent jaw reflex, tonic bite reflex is absent. Cranial nerve number 7, facial nerve, examine the facial asymmetry, raise the eye to ask the patient to raise the upper brow and find there will be wrinkles of forehead or not. Ask the patient to puff out cheeks and pucker and spread the lips. In pseudobulbar, it will shows paralysis of the lower half of the face, and the paralysis is the unilateral. In bulbar palsy, paralysis of the upper forehead and lower half of the face, paralysis is unilateral or by the examination of the cranial nerve. Number 9, glossopharyngeal nerve, and number 10, vagus nerve. They examine the position of the uvula, examine palatal asymmetry and uvular deviation by asking the patient to open their mouth and say ah. Gag reflex, examine the vocal folds. In pseudobulbar palsy, the muscular palate has normal strength, hyperactive gag reflex, normal appearance of palatopharyngeal folds and vocal folds. In lower motor neuron lesion, bulbar palsy, weakness of muscular palate, asymmetry of muscle palatal movement is common, absent gag reflex, uvular deviation, flattening of palatopharyngeal folds, and vocal folds paralysis. Cranial nerve number 12, hypoglossal nerve, inspection of the tongue for deviation, if it is right or left deviation, wasting, fasciculation, abnormal movements, power of the tongue, movement of the tongue up, down, and left, right, and rotatory movement, movement inside the mouth, push against each cheek. In pseudobulbar palsy, tongue movement are dysfunctional but present. Tongue protrusion reflects exaggerated and prolonged in duration. In lower motor neuron lesion, bulbar palsy, absent of tongue movement, wasting and fasciculation, tongue deviation towards side of the lesion in the lower motor neuron lesion. Then you take the neurological examination, the motor system inspection, state of muscle, normal atrophy, hypertrophy, if there is fasciculation and or fibrillation, involuntary movement in case of chorea, athetosis, dystonia. Then examine the muscle tone, if it is normal, increase spasticity or rigidity, decrease in muscle tone. Examine the muscle motor power, normal, decrease, deep reflexes and superficial reflexes, and examine the sensory system and coordination. It is normal in or there is incoordination, and examine the gait of the patient. Formal testing, you do the articulation test and dysphasia test if the problem is associated with language problem. Evaluation of the cognitive and perceptual abilities. Then you analyze your findings and go to the diagnosis and type of dysarthria, if it is flaccid or spastic, ataxic, hypokinetic, hyperkinetic, mixed dysarthria. And then you write down your recommendation. The therapy of dysarthria is tailored according to the affected motor speech process, respiration, phonation, articulation, resonance, or prosody. Thank you.